This 17.3mm nanophtalmic eye presents with a crowded anterior segment, a shallow anterior chamber measuring only 2mm, and angle closure glaucoma. Despite maximal medical therapy, the intraocular pressure remained uncontrolled at 32mm of mercury. In this case, we perform clear lens exchange to deepen the anterior chamber, open the angle, and achieve a better intraocular pressure control. The extremely short axial length required a calculated IOL power of 40 diopters, and a previous peripheral laser iridectomy is clearly visible. So let's review the surgery step by step. Intraoperative gonioscopy confirms closed angle. We begin with paracentesis and an intracameral mydriatic injection. A dispersive viscoelastic is injected first, followed by a cohesive viscoelastic. In these eyes, it's extremely important to achieve adequate chamber deepening with a good viscoelastic fill, because iris prolapse is a major concern in nanophtalmic eyes. A long tunneled corneal incision is created to improve the chamber stability and minimize the risk of iris prolapse. As we start the capsular rhexis, some viscoelastic burps out through the incision. Here the rhexis begins to run out due to viscoelastic loss and high posterior pressure. So we simply stop, refill the anterior chamber with viscoelastic, and flatten the anterior capsule, restore the pressure balance, and safely complete the rhexis. Gentle hydrodissection is then performed, and the nucleus is carefully rotated. So for nucleus removal, we choose the divide and conquer technique. In nanophtalmic eyes, the lens occupies a large proportion of the intraocular volume while the anterior chamber remains shallow. So to minimize the endothelial risk, the nucleus is kept within the capsular bag and divided into smaller fragments before sequential phacoemulsification. Throughout the phacoemulsification, infusion pressure is carefully adjusted to maintain a deep and stable anterior chamber without overpressurizing the eye. Before removing the phacoprobe, the foot paddle is returned to position 0. Viscoelastic is injected through the side port to maintain chamber stability and prevent chamber collapse. So this step is absolutely critical. We must avoid shallowing of the anterior chamber, loss of intraocular pressure, and hypotony, which can lead to complications such as choroidal effusion or even intraoperative malignant glaucoma. The remaining cortex is removed using irrigation aspiration probe, followed by gentle capsular polishing. Again, before withdrawing the irrigation aspiration probe, the foot paddle is placed in position 0. The capsular bag is filled with a cohesive viscoelastic. The calculated IOL power was 40 diopters. However, because this lens was not available, a 36 diopter intraocular lens was implanted in the capsular bag. The remaining viscoelastic is removed and the corneal incisions are sealed and hydrated. At postoperative day 12, the anterior chamber remains deep and stable with a partial reopening of the iridocorneal angle. The intraocular pressure decreased to 12 millimeters of mercury, confirming the effectiveness of clear lens exchange in this nanophtalmic eye. Thank you for watching.